Great question. So the question is, how do I choose my blog topics? And for those of you that are not following the blog, there is a card on your seat, and on the side that is more darkly colored, there's a web address. Top one there is to my blog. So I suggest that if you don't follow it, that you do, because this is a really great way for me to communicate information that I think is worth you knowing. And also, you have the opportunity to write questions in on the blog, and then I answer those questions. And Roya is my blog editor. So the way that we choose topics is that we look to several things. First of all, the main purpose of the blog was to chronicle our journey to accountable care. And the biggest reason that we started it is I wanted a way to reach more employees and physicians so that they would know what we're doing, why we're doing it, how we're doing it, and be able to connect those dots. So we've been using it to chronicle our journey now we'll be coming up on 2 years. Holy smokes. So we've been chronicling that journey. That's the major purpose. The other thing, though, what I didn't realize at the time when we started it, because I really intended it to be for employees and physicians and our boards and so forth, but what I found is we got quite a following. And so some of our competitors are following it, which is fine. I'm flattered. But a lot of people in the community are following it. And actually, it started receiving more of a national following because, as best I can tell, I'm not aware of another health system executive that's doing a blog about ours is I think attracting a lot of national attention. In fact, we have had people write in with questions from international sites. So it's been a very interesting process. So one is to chronicle that. The other purpose of the blog and what we do with stories is what are issues that are facing our country or our state in healthcare that are complicated that the public needs to understand. And so what I've tried to do in as unbiased a way as I can to present information about those topics for everyone, and knowing that your families and friends and neighbors know you work for St. Luke's and you're likely to be asked about some of these topics. So I put the information out there. I try to make it very understandable. I try not to insert my own opinion or St. Luke's opinion until the end. And I'll present the pros and cons, and then I'll say, here's where St. Luke's comes out on that. So that's been things like the insurance exchanges. Is that a good thing? Is that a bad thing? Should we have a state insurance exchange, or should we have the federal exchange? What about Medicaid expansion? Is that a good thing or a bad thing? During the healthcare reform legal challenge, I posted information explaining what are the issues that are being contested and explaining that for people who are not attorneys, and at times, indicating what I thought the court was likely to do with the case. And then, actually, one of our highest traffic days to the blog is when I wrote a breaking news story on what the Supreme Court's decision was. And Roy and I have talked a lot about why do we think we get so much traffic to the blog, and we really think that part of it is just not only has politics become so polarized, even the media outlets are so polarized, and you get these distinctly different views, but who's out there kind of just explaining this for people and trying to present it in a fair way. So I think that's one of the attractions. More recently, what we've been doing is selecting topics to highlight how St. Luke's is actually transforming healthcare, so that it's not just words. We're not just saying this is all the great stuff we plan to do. Here's the evidence of what we're doing. Here, let's profile things. And one of the things to get the word out to all of you is that when we are selecting these topics, it's usually Roya and I sitting down and thinking, what all do we know? Well, we don't know everything that's going around the health system. So one of the things that we would love is if you all would identify things for me that you think people need to know about so that we can get those stories. And a lot of times, more recently on these kind of stories of things happening around the health system, I've asked either Roya or Holly or Shireen or others to go out there and interview people and write the story, and then we profile that on the blog. So it's a great way to find out what's going on, get inspired, get some ideas, but we want to hear from you about what things you would like us to cover too. Great question, thank you. We have one right up here.
Dr. Pate, could you give us an update on the plans to expand EPIC throughout the system?
Sure. So with respect to EPIC, My St. Luke's, we have now completed phase one with respect to implementation. Right now, a lot of work is still ongoing because we're trying to optimize all of those flows and patient services, but the implementation has, for phase one, has been completed. The next step is we did receive approval from the board for phase two, and phase two will be the hospital implementation of My St. Luke's. That will require a lot of planning, training, and preparation, and so that's about an 18-month process before anybody would actually see something in the hospitals. But I think getting phase one in, which was our ambulatory settings for our physicians, helped us to learn a lot. Implementing it in revenue and revenue cycle has helped provide a foundation. And now I think the phase two going into the hospitals, we've learned a lot of lessons and we'll be even better about that. So that's the next phase. Also, another thing that's going on with respect to this is we are developing what we call our affiliate program. This is a way to offer EPIC to physicians who are not in our employer, not in the St. Luke's Clinic. And we are anticipating starting that as a pilot. Women's Health Associates. So it's we're going to, actually their practice is paper, so it's not converting them from one electronic medical record to another. They're paper, and we're going to, as part our first pilot of the affiliate program, install EPIC for their practice. So that we're looking at end of the year to first quarter of the next calendar year. So that's the time frame for that. Yeah.
Dr. Pate, we have a question online.
Okay.
From Sandy Ulrich, who asks, what was the driving factor for building an outpatient surgery center on the north side of Meridian?
What was the driving factor for building a surgery center on the north side of Meridian? What that is, and if you go to the Meridian Hospital, you'll see it under construction over by the, I think it's called the Portico building over there. We, at Meridian, we've had all of our surgery lumped together in the hospital, both inpatient and outpatient surgery. And we've had some capacity challenges with that. And for those of you that have worked in surgery, you know that can be a challenge kind of mixing both inpatient and outpatient. So one thing was a desire to have a separate outpatient surgery setting for services at Meridian and relieve some of that capacity bottleneck. We could be focused on really streamlining the processes, making it very efficient, and so we are delivering on that promise now. So that's the background to that.
Ron asks, how is phase 2 for EPIC being staffed up across the system?
Once the board approved phase 2, we began hiring for additional positions. Dr. Chasen posted positions for specifically that are needed for Phase 2. Mark, have all those been hired? All except for 6 people have been hired. So there still is an opportunity for 6 of you to move into this position, but we are staffing up for Phase 2. It's a great question. So for those of you that don't know what sequestration is, you have to go back to Congress last year, and what was facing Congress was a federal deficit that we need to address, and the federal deficit was really quite alarming, and so what was set out was goals of how much we needed to reduce the federal deficit by over 10 years. And then ensued, at nobody's surprise, a squabble between Republicans and Democrats as to how you would get to that federal reduction over the 10 years. And not surprisingly, with Democrats wanting to protect spending in certain categories and Republicans wanting to protect spending in other areas. And the problem is, if you protected all that spending, there was no way to get the deficit down. And knowing that, Congress put in kind of a poison pill, if you will. And that said that if we can't come up with an agreement on this amount of savings, then we are going to implement a sequester in January. It would have been January of 2013. And this sequester is an across-the-board cut. It would be similar to us saying, we're not doing well on our budget performance, and so we got to take a 5% cut across the organization. Every department cut 5%. Well, most organizations, although that's kind of the easy way to make cuts, it's really not very effective because everybody knows some areas are more lean than others, and there's some things that are really vital and crucial, and if that's what's in that department, then cutting it is going to be a problem. But that's what the sequester did. Now, there were a couple of protections. It would not impact some of the, for example, Social Security. It would not impact the Medicare beneficiaries. So there were some things that were protected. But what it meant for health care was that we were going to have a 2% across-the-board cut in our Medicare reimbursement, and then there would be impact on the states that would further impact Medicaid and some other things. So the sequester was set to go into effect January 1st or January 2nd. Congress took an action to delay that until March, and it did go into effect in March. And we are now experiencing cuts to our revenue from the sequester. And so we are feeling the pain of that. Now, in the total scheme of things of what we're experiencing, sequestration is just one small part. I mean, we have a lot of things that we're dealing with. One is that, as I said, we're committed to transforming healthcare. So we have investments in our current business, and we're making investments in preparing ourselves for accountable care. Investments like we're making into White Cloud for data analytics to allow us to make decisions that will allow us to manage patients in new ways. Investments into new programs to prepare us for accountable care. And that is something that's hurting us because now that's a lot of expense. The investment we're making into Epic is a huge investment. It's one, I think, it's foundational. We need to make it, but it's a lot of money that we're having to invest in there. Then you have the sequester. Then we have, when healthcare reform was enacted, during that process of negotiation, the hospitals, through the American Hospital Association, offered up a large amount of cuts based on the premise that the healthcare reform bill was going to cover more people, so now they'd be insured, we would have less charity and bad debt, and so we would offer that in a cut that they could put into the Affordable Care Act. Well, that was at the time when the Affordable Care Act required all the states to expand their Medicaid programs, which was going to be a very good thing for the state of Idaho, and in turn would help hospitals who take care of a lot of folks that are currently indigent, but now might qualify for Medicaid. And even though Medicaid doesn't cover our costs, it's a lot better than nothing. The problem is that case subsequently went to the Supreme Court. The Supreme Court said you cannot force the states to do this. All the states get to make their own choice. And thus far, Idaho has not made a decision to expand Medicaid. During this same time, because Medicaid was going to be expanded and all, there were additional cuts that were going to be made to hospitals, including loss of so-called disproportionate share funds. Those are going to happen now. So between the loss of the disproportionate share funds and the cuts in reimbursement inserted into the law, if Idaho does not expand Medicaid, the hospitals in Idaho are going to take a significant cut. So there's many things facing us. And I think that, what we're seeing, certainly we've seen some decline in our operating performance, and I think a lot of you have heard about this and are hearing about the steps that we're taking to deal with this. I have to tell you, I just think this is the new normal. We've had some rough spots in the past that have been blips, and seasonal or temporary, and then we've recovered from that. I don't think this one's going away. We had some hope that Congress might, but very little, that Congress might actually reverse the sequester because the economy was improving, the deficit was declining, healthcare spending was lower than projected, but they haven't, and I don't know if they will. And so I just think that we're just going to be, the new normal is seeing more and more cuts. That means that we have to address our cost structure. We have to try to manage our costs the best we can. But I do think that when we make this transformation to the new kind of business that we need to really manage the costs, I think we will be really well positioned. In fact, I think we'll be the best positioned in Idaho. Good question.
Pate, we have a question from Marvin Hull of Medical Imaging. Marvin asks, have you set a goal or challenge toward others for Fit One?
For what?
Fit
Fit One. Mm-hmm. Have I set a goal or challenge for Fit One? For those of you that don't know what Fit One is, for the past 20 years, St. Luke's has been the sponsor of the Women's Fitness Celebration. And it's a wonderful event. But recently, the founder, Ann Aldane, as well as our own folks, thought, we need to do something to spruce this up a bit after 20 years. So they decided to re-image it and do the Fit One, is what we call it now. And we have brought on staff for that, and Kristen Armstrong now is on board and works with that program. And what we're trying to do is, first of all, we want to use this as a way to engage even more of the communities that we serve. So one thing is we've kind of repurposed it. We're going to do some new exciting things. I have not heard what the goals are from that program, but we'll see. And they already have their own website, Fit One. So if you want to go to the website, there might be some more information and specifics there. So the question is, has our partnership with Select Health been successful, and has the feedback from the communities been positive? Yes, it has been very, very positive. And here's what I can point to for specifics. Just having brought Select Health into this market has already lowered insurance premiums I read an article in the Mountain Express in Wood River talking about some of the small employers. Small employers really face very tough challenges. And so Select Health has been a great opportunity for them. So yes, it's doing great. They're meeting their projections. We hope that it's going to continue to grow. Has St. Luke's given any consideration to inpatient hospice services? Not to my knowledge. But back to your question about providing some of these services virtually, I think that is one of the big transformations you're going to see from St. Luke's over the ensuing next couple of years, is that we're going to be offering many more services virtually or electronically. First of all, hopefully many of you are aware of our EICU. EICU is a program where we have, based in a room at Boise, a whole bunch of monitors that intensive care physicians and nurses sit around, and then we can tap into Meridian, Magic Valley, Wood River, and to their intensive care units, and our folks can actually provide support to them. There aren't any intensivists, to my knowledge, outside of the city of Boise. And so having these services that we can offer allows more patients to remain close to home. Already heard a great success story in Wood River. And if we can avoid having to helicopter somebody in from Wood River who could actually be cared for there, you're saving a lot of costs. Not only that, sometimes weather gets so bad in Wood River that it's going to be a significant delay in getting a helicopter there. So the fact that we can now team up with the staff there at Wood River and provide resources through EICU to support them to take care of that patient is going to mean better care at a lower cost and better outcomes. So very excited about that. We have a real problem in this country that there aren't enough intensive care specialists. Right now, only about 1 in 3 intensive care unit patients is actually seen by an intensive care specialist, even though that we know the outcomes are better when an intensive care physician is involved. So this is a way for us to extend those services. I envision that we will use this kind of service in many more opportunities, like telepsychiatry, so that we can offer psychiatry and behavioral health, and emotional needs are a big unmet need around Idaho. And you can't have, first of all, there aren't enough psychiatrists. Second of all, we can't have them all on the road all the time. We need them seeing patients. And frankly, for a lot of the care, you don't have to be there in person. So we can do that through telemedicine. And we're just doing a whole lot more services that way, I think. And it's going to be much more convenient for patients and better care in particularly a lot of our rural areas. So the employee survey went out today. And what goals do I have? And what are my expectations on leaders? The first thing is, my first expectation is for employees to take the survey. We want to hear from employees. Now, I also know that there's probably going to be some things I don't want to hear, but I need to. I need to hear those things. We're going through unprecedented change. I would be surprised if people aren't a bit unsettled. But what I'm hoping is that our efforts to communicate and to make sure that our employees understand what we're doing and why we're doing it. And employees may not agree with every single thing we're doing. I mean, that's natural. But what I hope is that employees will have a sense of, I understand where the direction we're going, I understand what we're doing, and I'm proud of our organization for leading, and I'm inspired by the things that we aspire to. And I hope that happens from the blog, from the forums, from the coffees, and from all the other communications that we try to do. But this survey gives us a chance to find out, are we connecting to you? I mean, there's 11,000 of you, and obviously you're not all here in this room, and so all of our efforts have to be incremental. We have to use a lot of different ways, but are we getting that message? And are managers getting that message to the employees? So the first thing is for employees to take the survey. Then, my expectation on managers is that if the employee honored us by taking the survey, you owe it to them to review the results with them. And so my expectation is that once the results are made available, that you would convene your staff, that you would review the results, and then the most important thing is, people typically are participating in a survey because they think that you will actually use this information. If they think you're never going to use this, they won't take time to do it. So our leaders need to take time, and I do this with my own leadership group when they take the survey. We sit down and we look for what are the opportunities for us to be better, and then what are your suggestions? Give me some feedback. Tell me what things we're doing that are really kind of a waste of time. What are the things we need to be doing we're not doing? How could we make this better? And solicit that feedback and then come up with some action plans. Here's what we're going to do for next year. And we've seen great examples of this. There's a manager in Magic Valley on the OB unit, Tricia. Tricia has implemented a whole lot of changes based on feedback from employees, including what she's doing is more recognition for her team. And sharing more information. She even created a departmental newsletter because not all the employees felt like they knew what was going on. So those are the kind of things that I expect leaders to do. And, if you're going to be a leader in this organization, one of the most important things that you can do is lead your teams. Because the studies show us repeatedly, people seldom leave their employer. They more often leave their boss, whoever they're reporting to. Unless there's a life change, you get married and you go off with a spouse or something. I mean, that's understandable. But overall, people leave their supervisor, not their employer. And so those relationships are very important. Thanks. Good question. Good question. So with all the new and emerging needs that we have, and certainly other organizations have, and new skill sets that we need, do we see the universities stepping up to meet that need? Yes and no. There are some areas that I think haven't been developed as much as they need to, particularly on the non-clinical side. I do see the universities really stepping up on the clinical side. And so we've got a new PA program because we're going to need more physician assistants. We have a program offered by one of the university for people that already have bachelor's degrees to do a kind of a fast track to getting their RN 15-month program, which I think is really good because a lot of people with the economic downturn did go to a second career, and so this is a way to meet some of the needs for nursing. We're seeing a lot more programs on postgraduate work for nurses so that nurses can get master's or doctoral. We're seeing a lot of other really good training coming out of the schools, and they've been very, very responsive. And we've partnered, for example, with Boise State University to do some things in an innovative way. For example, our pediatric GATE program. And what that is a program for children that have disturbances of their gait that need to be diagnosed, and it takes a very complicated, sophisticated, and expensive system to do that. You actually wire them all up, and then you have them walk, and you have all these cameras from all angles, and they film them, and then it does all these studies for it. And it's something that at our children's hospital, we probably couldn't afford to have a full-time program like that. But Boise State wanted to do some research along those lines, so we partnered with them. We put it at Boise State so we can take patients over there and when we need the clinical time, but then they can do their research and other things on the rest of the time. So by partnering, we've made really good use, and we now have a program that actually very few children's hospitals in the country have because it doesn't make sense necessarily. But these are innovative partnerships that we're doing. So I would say largely yes, but not completely. I think there's some areas that still need a lot of work, like in the technology fields, and I think technology is going to be an increasingly more important part for healthcare, and I haven't seen that responsiveness yet. But others in the state are complaining about that, and I think it will get addressed. Good question. So thanks for being here. Any last questions? Anything? Thanks for being here. Have a great day.